It wasn't on public, it was on private mode before, now it's on public. So give it 5, 4, 3, 2, 1. I think it's live. So can you check it and see if you can see it on my wall? Can you go back to my wall and see if you can see it? Refresh your page.
Yes, I can see now.
Yeah, it's here.
Okay, now I can see it.
Okay. Yeah, it was on
Now
private mode.
I can see it.
Okay.
Why?
Just refresh your page.
Right, it's clear now. You can see clearly.
Okay,
Okay,
it's
okay.
there now.
Yeah.
Doctor Global. Okay, yeah, I can see it now.
Taja, can you see it?
Yes, I can.
All right. Can you take your camera off? Because we're going to start in 10. We're going to start in 20, 19, 18,
Edward,
17. Can you pause your... Can you mute your speakers, please? Everybody mute your speakers except the person that is talking, please. 17, 16, 15, 14, 10, 9, 7, 6, 5, 4, 3, 2, 1. Hello, everyone. Welcome to our maiden edition of Doctors Conference. We're going to be making sense of the whole news that's going about in town. I know there are different things that you must have heard from WHO, from CDC, from Africa, from Australia, from Madagascar, latest trends from Madagascar. So we're going to be having this session every Sunday. We're telling the world, trying to summarize, so we call it the meta-analysis, all these figures, we're trying to piece it together. With me here, doctors from all over the world. We have people from Nigeria, we have people from Canada, we have people from UK. And they are in various specialties. I'm going to introduce them one after the other. So they are specialists in different fields that are going to make sense of what is happening in the different field. We also have a COVID-19 life survivor who have, appealed to come to this show to tell the world about her personal experience. I know a lot of people must have heard about this COVID, people are getting sick, but they've never seen someone that has actually gone through the valley of shadow of death. So her name is Mrs. Barr, and she's live on Facebook. Also, you can go to her page. Everybody's live on Facebook. You can go to her page. She's also on Twitter. We're sharing it on YouTube. Also, you can also share it on your own page so that the world can hear about this analysis. First, I'll begin from my extreme left or right, depending on how you're looking at it, but just indicate within your hand is Dr. Joseph. Dr. Joseph is a specialist obstetric and gynecology. He's also a specialist in infectious disease, and he's going to be telling us from the obstetric parts and also from the infectious disease part, what has been going on in to the pregnant women and their children and the rest. Other people that we have also is Dr. Saiki Orinamo. Dr. Saiki Orinamo is a specialist ear, nose, and throat surgeon. He's going to be telling us about all this ear, nose, and throat, how COVID is related to it. We also have to my down, Dr. Egbe. Dr. Egbe is a general practitioner. She's in UK. She's going to be telling us her experiences in UK and the rest. To my extreme left, we have Dr. Cyril Basuyi. You can see he's wearing his eyeglasses. So he's an ophthalmologist, a specialist ophthalmologist, and he's going to be telling us, the relations with COVID-19. And they're not only going to be talking about their field, they're also going to be talking about everything. So on top of Dr. Cyril is Dr. Omar. Dr. Omar is a specialist radiologist. So she actually looks at X-ray films, radiological interventions, and she knows a lot about how this virus presents. And going further up, we have Dr. Moye. Dr. Moye is from Nigeria. She's also is disease specialist in her own perspective. She's going to be telling us much about controls and the rest. Right in the middle is Dr. OJ. Dr. OJ is a specialist in internal medicine. He has managed a lot of patients. Everybody here have managed in one capacity or another this COVID patient, but Dr. OJ has managed patients in intensive care and also in ward, and she's going to be telling us a lot of experiences. Then down under Dr. OJ is Mrs. Barr, the COVID survivor. Mrs. Barr, how are you doing?
I'm doing fine today, thank God.
Good.
I'm getting better every day.
Thank God. Yeah, Mrs. Barr has given us a HIPAA waiver. So she has given us permission to feature her live on air. And just for a note, whatever we're going to say is from our own personal, professional perspective, we're not representing our hospitals, we're not representing any organization. These are a collection of the finest brains in the world coming together to share, to make sense out of this data. It's personal and not a representative of the hospital. So we're not going to be mentioning I work in this hospital or he works in that hospital in this particular presentation. So Mrs. Barr, can you tell us a little bit, just your experience? How was it, COVID-19? You're the first person many people are going to see that actually have this disease and have survived it.
Yes.
If you don't mind sharing your age so that they will know that it doesn't have any age predilection and the rest.
So I'm 29 years old and I'm a registered nurse. Yeah, I work in the healthcare field. And this experience has been one of the most terrifying thing I've ever gone through. Not the fact that even I was sick, it's just that, knowing that I live with my sister and she has 2 younger kids in the house, that's just even, made everything just to the extreme. So I was sick and I was in pain and I have this worry in me, like, am I going to transmit this to my sister's kids? Am I going to transmit this to my mom? So that fear just made everything more to the emotionally draining. So my symptoms started a couple of weeks ago. And the first thing that I noticed that when I came home, I was tired and I kept on stretching, like my bones were hurting. So I just thought I was just being tired. So I took a nap, could not sleep. I had a terrible headache. The headache was like in the back of my eyes. It felt like pressure, like somebody was putting pressure in the back of my eyes. I could not lay down. The more I lay down, the more the headache gets worse. So I have to prop my pillows up and sit down. I took Tylenol, Excedrin, nothing worked. So I was with that headache and the body pain all through the day on Tuesday. And overnight on Tuesday, I started having a fever. I had a temperature of 103.8. That was the highest that I had. And I had chills. I was sweating. I could not sleep. I had this stomach ache, just like I had a stomach virus. And I was going to the bathroom. So the next morning, I woke up after sleeping for like 2 hours or so. I woke up with the most excruciating body pain. My muscles and my bones were all hurting. My joints were painful. Like I could barely get out of bed. And I had this feeling that my chest was tightening, like you're trying to blow a balloon. And it's very hard for me to take breath in. So I kind of got up and I kind of felt like I was just getting anxious. So I was able to go downstairs and get something to, make something to eat. Then I would notice I could not smell. I could not smell the food that I was making, which was weird. And I was actually, my sister was making some African food. You know how we have the fish and all that? And I was like, I cannot smell what you're cooking. She's like, are you serious? I said, yeah, I cannot smell it. So I took some bleach, put it right up to my nose. I could not smell. I totally lost my sense of smell. And I said, okay. Yeah. And I made some oatmeal. I noticed I was putting so much sugar in the oatmeal for me to taste it. My sense of taste was like not totally gone, but very decreased. So I had to put like a lot of sugar in my oatmeal so I can taste it. So I'm like, something is not right. I took my blood pressure, it was fine. I checked my temperature. That morning when I checked, it was 101.4. So I took another dose of Tylenol. And I called my doctor who told me to go get tested. through the drive-through. I went to get tested, came back home. The symptoms got worse. Fever, chills, I'm shaking, my body's hurting. So that was the symptoms that I experienced. So I don't know if you guys have any
Wow.
questions before I go into, some of the treatments that I
Wow.
took.
It sounds to me as a doctor, it sounds a little bit like an everyday symptom that people get to you. I know it to be scary because of the anosmia. The anosmia is loss of smell.
Yes.
Wow.
Yes.
How were you frightened?
Yes, I was scared because that's something I've never experienced before. I've experienced pain, headaches. I've experienced all of that before, but losing the sense of smell, I'm like, and being a nurse, I'm thinking, oh my God, is something happening? Am I losing, am I losing functions in my nerves or what's going on? So it's like, I'm thinking about everything, what's going on. It was after when I spoke to my doctor and I told him that's the symptoms that I'm having. And he's like, oh, don't worry about the sense of smell. A lot of people that's positive for COVID usually have that, that symptom, which is something I've never heard of. Because on the news, everything they talk about COVID is, coughing, sneezing, shortness of breath, and difficulty breathing. So I did not have that. I didn't have too much of the coughing and all that. It was more just this intermittent chest tightening that I had, but not to the point that because I have my O2 sat, my oxygen pulse ox, so I checked it, not to the point that my oxygen level was below 90. So I was like, okay. So does losing the sense of smell really freaked me out because the media talked nothing about it. So that was, one thing that really, I think we should put out there.
Oh, wow. So I'll just ask you one more thing, and if you can hang around with us so that the experts can go into details on all these things. How do you think, I know it's difficult to say, did you come across someone that had COVID? I don't want you to, expose or to talk about other people, but in what scenario do you think you got it?
I don't want to say 100% definitely I got it from my job, but I'm almost 80% sure that I got it there because I know certain patients that I worked with that were later diagnosed with COVID, and some of them sadly passed. So I think I got it from, taking care of patients in a long-term care facility.
Oh, I see. That's so very distressing. Thank you so much for giving us this account. I know a lot of our audience are asking so many questions and they are directing it to you personally. So just hang on a little bit with us. Before we take the questions, we'll just go straight to the introduction serial. Just introduce this COVID-19 for us.
Yeah, good evening. We're talking today about COVID-19. We're trying to get grips on COVID-19, try to wrap our head on COVID-19. COVID-19 is a disease caused by the severe acute respiratory syndrome coronavirus 2, closely related to the severe acute syndrome virus, which showed up some years back. It's part of the corona family. It's an RNA virus, predominantly affects the respiratory system and predominantly transmitted by respiratory droplets. We actually are getting to know a little bit about coronavirus 2 presently. Initially, a lot wasn't known, but thankfully, data is coming out. People sharing their experiences, people are sharing their healthcare experiences, and we're getting to know that coronavirus, we're getting to know a lot about its transmission, we're getting to know a lot about its incubation period, getting to know a lot about how people share this virus. A quick note on that, studies have shown that the virus could incubate for as much as 14 days. Some studies have shown as much as 37 days. And important to note that when people incubate the virus, they can also spread the virus without being symptomatic. So they could not have, they would not show any sign of a respiratory illness. They may not show any sign of a flu. They may be just as healthy as you and I, but they're still able to shed the virus. So that's it's one of the reasons why face cloth covering has been advocated. It has been shown that a face mask can prevent shedding of virus by asymptomatic carriers. And that's part of the reasons why face masks have been advocated. When people with COVID-19 become symptomatic, varying symptoms may arise. Presently, it's been recognized that anosmia, a loss of loss of smell and loss of taste, can show up. Diarrhea, acute diarrhea, cough, chest tightness, difficulty in breathing, as some of the symptoms which the patient may complain of when these patients have COVID-19. As we go on, I think we'll go deep. We'll talk deeper and talk in depth about this disease.
Thank you so much. Thank you so much. Dr. Joseph, you're an infectious disease specialist. Can you shed more light from an infectious disease aspect? If you have studies, if you know history, just go a little bit more in depth. Cyril did a very wonderful job introducing it.
Yeah, just like Sylvia has said, it's a novel disease. COVID-19 is actually an acronym for coronavirus disease of 2019. Is a potentially severe respiratory tract disease caused by the SARS-CoV-2, which we had mentioned, an RNA virus that has the shape of a crown. It's a novel disease, it's new to us. And not so much is known about this virus for now. And as we speak, so many studies are still ongoing. The first case of coronavirus disease was reported in December 31st, 2019 by the World Health Organization following an outbreak of pneumonia of unknown origin. Yeah, that was actually how it was reported. And by the 30th of January, the World Health Organization had declared the disease as the public health emergency of international concern. In fact, they raised this alarm as far back as 30th of January, 2020. By March 11th, they had declared the disease as a pandemic. At this time, so in fact, the disease has spread over all the continents of the world. The first case in Nigeria was reported in February 27th, 2020. And just within 4 weeks, 3 to 4 weeks, we had recorded about 51 cases of coronavirus in Nigeria. Although higher incidents were reported in other parts of the world, like the US and the UK, we reported about 51 cases as at March 25th, 2020. And just within 4 weeks, between March 25th to April 25th yesterday, we had reported about 1,182 cases of this disease. As the testing centers are increasing, we are reporting more cases. The case fatality rate from March 25th, which was just about one mortality at that time, just one case of death recorded as at March 25th, 2020, but recording about 35 cases now of
wow, that's very astonishing.
Affected person. So it's still there. We are still very hopeful. We are just hoping that it doesn't. We're able to control this increasing epidemic, because growing from it has grown from epidemic proportion into a pandemic proportion, and we are having more cases now because unlike in developed parts of the world, we don't have much resources, to control or curb this disease. So we are very hopeful that it ends this way, And then
Right. So the thing is, it's a global problem, and every country. He just talked about a problem that's affecting a particular country in Africa, that is in Nigeria. We're going to turn to Dr. Igbe, who's a general practitioner, also an infectious disease, very knowledgeable in infectious disease, and she's going to tell us more about the global epidemiology, just hit the points so that everybody can understand. By the global epidemiology, because we're talking to dual audience, both the normal people, and we're also talking to professionals like us. The epidemiology is going to cover the age groups that it affects, why does it affect those age groups, and any other thing you could talk about it. Go ahead, Dr. B.
Hi, everyone. Thanks for having me on this show. So coronavirus, as a lot of us, as a lot of the other speakers have already alluded to, is making the headlines at the moment and has been so all over the world for the last couple of weeks. Delving straight into the epidemiology, at the moment, as it stands, we have about 2,966 cases, 489 of COVID-19. So that's more or less nearly 3 million. So that's to tell you how prevalent this disease is, okay? And so far, we've had about the world over, we've had about 205, nearly 206,000 deaths from this disease. And if you go on the WHO website and another website, the Worldometer site, you can see how this has affected different countries around the world. So it was a disease that started in China and spread very quickly around the world. And there are many reasons for that. We know that international travel is one of the biggest reasons why this disease spread so quickly, because the world has become a global village. So within a few weeks of that first recognized case in Wuhan, Hubei in China, in December, as it stands, as my colleague said earlier, it's in every country or nearly every country in the world. And as one of my colleagues mentioned earlier, well, the trend that we find is that countries that test more report more incidents, because there are a lot of people in the community who have had these symptoms who may not end up in hospital. And so we see that countries that test more tend to report a higher incidence. As it stands, from what I can see, it seems that the United States of America has the most number of cases, about 970,000 cases, and about 54,000 deaths. So this is a disease, and in the United Kingdom, the cases I have here in front of me is about 152,000 cases with over 20,000 deaths, okay? And the world over, I mean, in Italy, they've had more than 26,000 deaths. In Spain, more than 23,000 deaths. That's to tell you the huge impact and the massive scale of this disease, okay? Now, in terms of the age distribution of the people that have been affected, what we are finding, and it's good that we have a very young, fit and well patient here, is to say that this disease does not respect age. So any age group can be affected, okay? And when this newly came to light, when we first started learning about the disease, the young people in particular thought they were invincible to this disease, and they were not actually taking precautions. But we have seen patients die, from every age group. Having said that, the disease is more likely to be severe in the oldest patients. So anybody above the age of 80 is more likely to be severely affected. So in the UK, for instance, patients above 70 years, regardless of comorbidities, have been told that they are high risk, and as much as possible, they should stay at home and isolate themselves. And this, you see, to help them, because if that subset gets the disease, they are more likely to have a more severe disease, okay? And so it's any age and any class. So we are finding that high-profile personalities, like our very dear Boris Johnson in the United Kingdom, the Prime Minister, was actually affected and ended up in ITU. So again, it's not poor, it's not a disease of the rich. it can affect anybody and everybody. Again, there are some myths out there that it affects only some colors, which is incorrect. So we can see that whether you are black, white, or whatever color your skin is, this disease can actually affect people of every color. So it's not a disease that discriminates. The disease is more likely to be milder in younger people, but the world over has seen patients that are very young without any pre-existing comorbidities dying from the disease. So that means that everybody should take necessary precaution. Yeah, there are people without underlying medical conditions in their 20s, in their 30s, in their 40s that are developing a severe disease and are ending up dead. Okay, the one thing to say is that it's not all bad news. A lot of people do recover from this disease, and a lot of people might only have mild symptoms. The problem is we don't know who is going to have mild, moderate, or severe, and that's why everybody must take necessary precautions. So as it stands today, about nearly 900,000 people have recovered. Having said that, there's no, as one of my colleagues said earlier, there's no test yet to be sure whether that confers an immunity. And if it does, we are not sure for how long. Will it be a short-term immunity or a long-term immunity? Okay?
Wow.
So that...
Go ahead, Ibe. You did an amazing job. Go ahead, I'm listening.
I wasn't sure if you wanted me to say anything on the transmission. I wasn't sure about that. Did you want me to say something?
Yeah, we'll get to that because we have a couple of questions. People are asking a lot of questions, and it's just an hour show. So we're trying to see how we can contain everything within today. Then on next week, Sunday, we continue for as many people that also want to tune in. This is our own contribution to humanity, to enlighten you. There's a disease out there. Be careful. We're going to go straight to the management. So like Mrs. Barr has this problem, right? We have people that have managed it in front line. Almost everybody has managed in one way or the other, but Dr. OJ, Dr. Omar, they've actually seen so much. They could just tell us from the management perspective, how do these patients, when they come in with what Haja said, are there other symptoms that you've noticed? How do you, what's the severity grade? How do you triage them? How do you send some people home, and how do you retain other people? Dr. J, are you there? Unmute yourself. So you're going to co-manage it with Omar, who is a radiologist, and Dr. Saiki also, who's a nose, ear, nose, and throat. Tell us what they see. There's a question for Dr. Hajar, not Dr. Hajar, Dr. Barr. Before you go to the management, someone sent a question from Maryland, USA, and it's trying to ask you, how do you feel right now? Do you feel you're getting better? You could just answer that quickly, then we just go.
Oh, you mean Miss Barr? Because I'm not a doctor.
Yeah, Miss Barr, Miss Barr, yeah.
Or Nurse Barr. Yeah, I'm feeling much better. Every day is a blessing. So I'm feeling better. Thank you for asking.
All right, because there are other questions too from our live Facebook feeds and our YouTube feed, but let's just go into management. Dr. Oj, over to you.
Hi, everyone. Ms. Barr, I really sympathize with you. I understand what it means to go through this very devastating illness. It's great to have everyone here and for everyone watching. I think the point of all this is to reinstate the fact that coronavirus is real. Out there are various myths and various misconceptions about it, but I think this is why we're doing this, to clarify most of the information that's out there. For me, I saw my first case of coronavirus on March 7th. Until date, I have seen over 600 cases of coronavirus infections in all shades. My hospital currently is a COVID hospital. I would say from my experience and what we say in the books, because right now, because it's a new disease, we are like writing our own book on our experiences so that we know how to treat other patients better. My colleagues have talked about this virus, about the demographic presentations in terms of epidemiology, but I really want to touch more on the clinical presentation. For the patients we've seen, it affects all ages. However, we found that most of the cases we've seen, at least more than 80%, is seen in patients above 65 years of age and also in the elderly population. And also with patients with a lot of comorbidities. Top on the list is obesity. It's highly prevalent in patients who are obese, diabetes, hypertensive patients, patients with heart disease, asthmatic patients, and patients with COPD, patients with chronic obstructive pulmonary disease, patients who smoke at very high risk of contracting this virus, and patients with cancers and some form of immunosuppression. So these patients are very, very, very well affected by coronavirus. And I think in developed worlds where we have a lot of elderly population and patients with multiple comorbidities, it's the reason why I think the mortality is higher in this environment. So majority of patients do not report any exposure. All right, as we said, some haven't been exposed to patients who have had the infection. Most patients do not even remember where they were exposed to this patient. I remember Ms. Barr saying she thinks she got it from her job. Yeah, that might be her own exposure, but most patients do not even remember. So some people would ask, I've not traveled to the UK, I've not been to US, I've not been to these prevalent countries, but I have coronavirus. So it's out there in the community. Community transmission is very high. So typically symptoms are usually mild, and they range from fever, fatigue, sore throat, loss of taste, loss of smell, cough, and shortness of breath. These are in various categories of severity. However, for these patients who come with very mild symptoms like fever, cough, shortness of breath, and very mild symptoms, loss of taste, the plan is to isolate them at home. So they don't need to come to the hospital so that they don't overwhelm the hospital facility. We barely come in contact with these patients because once they get tested and we know it's COVID, we just tell them isolate yourself at home. So do not come to the hospital. So I typically do not see mild cases because they don't come to the hospital. They get tested. Right now in the United States, we have outpatient testing facilities. You could walk. There are some drive-thrus where you could go get your swab taken and get diagnosed with COVID. So you stay at home. Even currently, if the healthcare professionals who have tested positive, they are asked to stay out of work for at least 10 to 14 days or 3 days after they are symptom-free. So I have a lot of colleagues who in the hospital, they've tested positive, but they've been symptom-free for like 3-4 days and they come to work. So mild symptoms at the order of the day. Now, the question is, with all fever now COVID, is all cough COVID? No. The typical influenza is out there, which could cause these symptoms. So most patients who are testing for COVID, we find out that we're getting more influenza and flu cases. Pneumonia is out there. There are a lot of other presentations that could give this typical symptom. But we encourage patients with these symptoms to go get tested. This helps to know the amount of patients who are infected in the community and helps us get resources. Now for the severe presentations, these are patients who, first of all, I said, typically they are high-risk patients. Typically the patients who come to the hospital at high risk, they come with their hypoxic, meaning that the oxygen levels in their blood are very low. I'm talking about patients hypoxic in 80s. When you check their O2 saturation, they are in 80s. Now, these patients, they come with cough, large amount of sputum. Some come with brought in patients with sudden cardiac death because this virus goes to the heart and causes viral myocarditis. So they come with sudden cardiac death. Some come brought in dead patients. Patients come with severe respiratory distress. But overall, the most typical severe symptoms we've seen, which warrants bringing to the hospital, are patients who are very, very short of breath. And these are the patients that will require to be intubated, require oxygen, and require some other forms of supportive and symptomatic management. I think I'll give a few. I wanted to talk about what we do when they come to the hospital. So when this patient typically come to the hospital, we label them as being suspected because the nasopharyngeal swab and the oropharyngeal swab test for COVID takes at least 24 to 48 hours to come out. So in the meantime,
so I'll be interrupting you. Yeah, I'll be interrupting you because I'm having a lot of questions and so many people that are not medically oriented. I know you're a medical specialist. When you say nasopharyngeal swab, Dr. Orinamo, what do you mean by nasopharyngeal so that people can understand it? Then he will continue.
All right, nasopharyngeal swab, what it means is that taking a swab from a layman language from the back of the nose. That is basically what it means by nasopharyngeal swab.
So they're going to put a swab
one of the
down into your
most
nose.
reliable methods behind. Yeah, dip the swab stick into the nose and go to the back of the nose. That's what we call the nasopharynx. Yeah, that's what we mean by nasopharynx.
All right, go ahead, OJ. You can continue.
All right, thank you very much, Dr. Runami, for that. So once the patient comes to the hospital with suspected COVID symptoms, we call them persons of, we call them suspected cases. So we, at this point, institute what we call the droplet precautions, and this is what should be done, I think, in every facility worldwide. Droplet precautions, because right now we're saying that the virus is transmitted through droplets. So this patient must wear a face mask if they're coughing, and any healthcare worker who have access to this patient must wear face masks, must be in a gown. This is according to the CDC recommendation. So usually these patients are put in an isolated room. They make contact precautions, droplet precautions, right? The swab test is taken. And if we have to do any aerosolized procedure, and that's when we consider that it might also be airborne. Aerosolizing procedure means procedures that disperse this patient secretions into the air. I mean, if we have to intubate this patient, meaning to put a tube down the patient's throat, this to help the patient, connect the patient to a ventilator and breathe for the patient. Also, if you have to put the patient on bronchodilator therapy, if you have to do nebulizing therapy, it means for patients who have asthma and COPD, they require nebulizing treatment. They have to put some aerosols, some medications, and aerosolize them to the airways. So these procedures could spread the particles of this virus in the hospital. So these are the patients we have to use the N95. We use the N95 mask for them, and we also have to get a face shield. So these patients are very high-risk patients, especially when we have to intubate this patient. Then we get a chest X-ray. The chest X-ray is very important, and I think we have a specialist radiologist in the house who can throw more light on the findings on the chest X-ray. This is very important because not every patient can get a CAT scan, within the period of presentation. Now, once the patient is suspected, we isolate the patient, we get a chest X-ray. We have mobile chest X-rays or facilities that are dedicated for COVID patients. So the chest X-ray finding is typical and has helped in diagnosis of patients. I think
Thank you.
Can talk about that.
Thank you, Dr. OJ. Thank you, Dr. OJ. Dr. Omwa, you're a specialist radiologist. Before you continue, there are some couple of questions, one for the survivor. Let's just quickly take it. It's going to be every Sunday thing, so we cannot cover the entire COVID-19, but you'll be sure to get something out every time you watch it, every time you watch this contribution to humanity. Question for survivor, what did you do or take that helped you? I know Dr. J is going to talk about specific management, and Dr. Francis is going to talk about newer ways of managing. But let's just hear from you. What do people do? Most people that have it, because I know so many people are sending in questions. Some are saying they're positive. So we just want to know from patient's perspective, what did you do? What are the specific things? There are other questions. Someone asked, can pregnant women get it? That's for Dr. Joseph, is a specialist obstetrician. There's another question. Are you worried about getting reinfected? We're going to talk about transmission. Dr. Igbe, Dr. Zainab is going to talk about transmission. Both of them are going to talk about it when we get there. One other question, how do we manage kids, especially 10 years or below? So lots of questions are coming in, lots of questions. So, but before then, Ms. Barr, if you could just answer that first one, then Omar will go ahead. We'll answer those questions, audience, whenever we get to that section. Thank you so much for your question.
Okay, so what I did that helped me, I went back home. We used to take routes back home when we were sick, and my mom gave me this route. We call it in our Creole language, bangba. I think there's a different name for in Nigeria, but I put that in my video. So it's a really bitter root and lemongrass tea. So those were the two things that I took exclusively, because the Tylenol, the Excedrin, everything else was not working. So I started taking the bangba and the lemongrass tea after the day I got back from testing. I started taking it, and by the evening, I noticed my fever is gone. So I guess the rationale behind my mom, making me do that is because that's what she used to give us back home for malaria. And most of the symptoms that I was having, the body aches and, the stomach pain, was like something with, people see with malaria. So I guess that's why she made me take those medications, and I start seeing improvement. I was taking it every 4 hours, every day. Up to now, I'm still taking it every day. And I'm recommending it to people too. So I don't know what's the relation there, but that's what I did.
All right, we're going to talk about treatment, because in medicine, there's what we call anecdotal treatment, and there's what we call evidence-based treatment. What she's talking about is that she took some native herbs, lemongrass and the rest. So those are anecdotal treatment. We're going to talk about it from the medical perspective. There's also a new herbal mixture that came out from Madagascar. They just recently announced it on TV that these things work. Well, we're going to talk about, we're going to divide it when we get to management and newer trends. Omar, go ahead. How do they present? They said they present with chest pain and we'll do an x-ray. Just take it from there. Dr. Omar, you just have to unmute yourself. Thank you.
Yeah, sorry. Thank you very much for having me here. And Ms. Ba, I'm so happy to see how well you've recovered. Okay, so according to what Dr. Oji said concerning the symptomatology, patients actually have more of chest symptoms than any other symptom. And here I would like to say that radiographic imaging has a relatively low specificity, meaning that patients that present with mild symptoms and those that are asymptomatic may actually not have any chest findings. Okay, so having said that, I'm going to share some images.
Go ahead, just share your screen.
Right. Okay, so I'm going to share some
images. Just share it. I'll load it up.
Okay, I don't know if you can hear them.
While she's preparing to share her screen, Dr. Joseph, can you? Oh, okay, the screen is up. Thank you.
Okay, so I'm going to basically talk on the CT imaging, because that's the imaging modality that actually shows the progression of this disease. It actually has 4 stages on CT. But at first, I will show a radiograph. This is a normal chest, so you know how it's supposed to look like. And the lungs are the darkest parts of this radiograph. Okay, they are the black part, the right and the left lungs. The white linear strands we're seeing are the blood vessels. So ideally, this is a clear lung. And the next image we'll see is a patient that has established COVID-19 disease. And this patient, we can see how white the periphery of the lungs are. This disease actually has predilection for the lateral lungs and more around the mid and the lower lung zones, with relative sparing of the upper or the apical zones, though every part can be affected, but it has predilection for mid and lower lung zones. And this shows the increase opacification. Opacification just means like whiteness of the lung periphery. So that's for the X-ray. Then now going further to the CT images, like I said, there are actually 4 stages for the CT presentation. We have the early and initial stage, which—
Do you have the image? Can you put it up?
Yes, I'm trying to load them.
Okay, well, while you're trying to load it, Dr. Joseph, someone is so concerned about pregnant women. How affected are pregnant women in this? Why Dr. Omar is putting up on the screen, putting up a CT?
Okay.
You're an obstetrician, and you must have read a lot about how it affects women and children.
Yeah, I want to say that the disease specifically does not spare any group. It affects both the pregnant adults and the non-pregnant adults. It also affects the children. You see, the symptoms are even more masked in pregnant women. That's why for the physician, you would need a high index of suspicion to make such a diagnosis in pregnant women. It's important. That's why every pregnant woman coming to you for routine antenatal care, at this rate, you have to be very suspicious. You need to have a high index of suspicion because some of the common symptoms you could have in pregnancy are related to some of those symptoms that have been described in COVID patients. And most of the health work, particularly doctors that have been infected in many parts of the world, actually got their infections following some procedures, such as cesarean section, from undiagnosed cases before such cases were done. Yeah, those are the issues we are having currently in many parts of Africa and in Nigeria particularly.
We'll come back to that so that we can continue on the flow of the trend where we've talked about the symptoms, how they present, talked about who and who can get it. And Dr. Omar is going deeper into details on how when you get to the hospital, how your lungs look like. This is a picture of the lung. Dr. Omar, go ahead from there. We'll take other questions after this session.
Okay, so I'm gonna go ahead now. Okay, thank you very much. Like I said earlier on, there are 4 stages on CT. You have the early or initial stage, which presents about 0 to 4 days. And this actually just shows ground glass opacification. I would explain it. Then this next stage to that is the progressive stage that happens around 5 to the 8th day. And it shows increased ground glass opacification and thickening of the lung markings. The 3rd stage is the peak stage, and that's the consolidative stage. It happens around the 9th to the 13th day. And the last stage is the absorptive stage where you have fibrosis. So now this is the first stage of the disease around the 0 to 4 days. And also remember that I said that many of the patients actually have normal lung at this stage, especially 0 to 2 days of being infected with the disease. So, but for those that present, we see the laterally, we also have, that's the periphery of the lung, both lungs, we have increased opacification, that's increased whiteness, as compared to the upper part of the lungs and the central area, there's increased whiteness. I'm going to use that so everybody will understand what I'm talking about. At the periphery, and it's more at the middle and the lower lungs. So this one actually enables us to see the vessels through it. So we're going to have to differentiate consolidation from ground glass opacification. So this is ground glass opacification because we can see there's whiteness, but we can see the vessels through it. So that's 0 to 4 days. Then the next stage is the 5 to the 8th day, which still shows the ground glass opacification. But in addition, we can see thickening of the lung markings. So the lung markings are thickened and making it really very obvious, giving this crazy paving appearance. I'm going to show the next clip now that coned down on a lung that has ground glass opacification and thickening. That's the white strands within that whiteness, that ground glass opacification. We can see then that gives the crazy paving. What I mean by crazy paving is just a pavement of broken tiles together. So this is the appearance. So we call it the crazy paving sign in radiology. So that's the 2nd stage. That's the progressive stage of the disease at the 5 to the 8th day. Then we have the consolidative stage at about the 9th to the 13th day. And this shows densely increased opacification. You can see that in this image here, we can actually not see the vessels through this whiteness that it's on the right lung at the periphery. Then on the left lung, we have it like a round morphology, but we can't see any vessels through it. It's just white. So this is the consolidative phase. And the round dark areas you can see within it are dilated bronchioles, which is actually a complication of this disease, bronchiectasis, dilatation of the airway within this consolidative area. So this happens at the peak stage of 9th to 13th day. Then the last stage of the disease, which is the absorptive stage, shows fibrosis.
Wow.
So we can see
Wow,
how
the lung is completely destroyed.
I could say
Wow.
it's so busy, you know. Exactly, you know. So it's not
Wow.
vessels we're actually seeing here. It's not just thickening of the lung markings. These are actually fibrotic strands. So this patient has had this disease and is progressing for
Okay.
over 14 days now. And we can see fluid at the left lung, the dependent portion of the left lung. So this patient also has pleural effusion. And these are other
Wow.
findings, but the typical ones are the ground glass opacification, the consolidative stage, the fibrosis, and of course the thickened lung markings. So this is how this patient's chest will present. One of
Thank
any
you.
of these four, it's actually the typical presentation depending on the stage of the disease. Thank you so much.
Thank you so much, Dr. Moore. Thank you so much. You can now
This is
return
so
the screen to
beautiful.
me. Yeah, this is so beautiful. Just end
Okay.
your screen sharing and return it to me.
Yeah.
Thank you so much. Amazing, amazing. So, Dr. J, what Dr. Omar, of course, I know you understand all the languages. The people out there, many of them are doctors, some of them are not doctors. We have questions coming in, over 30 questions now pouring in. I don't think we can take all of them, but we'll just ask a few. Someone asked Dr. Theophilos from Canada, asked Dr. Mo, hello, Dr. Mo, I wanted to find out if that patient with the chest radiograph survived or not. So in terms of answering about who survived or who doesn't survive, Dr. J will take the treatment. So when they have all these things, all these symptoms, how do you treat them? What do you do?
Okay, hi, Omar, thank you so much. That was a very, very, very good
Sorry,
presentation.
just a quick one. There are other
Yeah.
things that are coming out, other questions. Possibility of fetal-maternal transmission, that's for the obstetrician. Are there possibilities of ocular presentation? Someone is asking from UK, that's for serial. Are there other things that look like this for in CT scan? Someone is asking that, that's for more prevention. We'll talk about prevention when we get there. So go ahead, Dr. J.
Okay.
We'll just be taking it one question at a time,
After the
but
other.
go ahead.
Yeah, that's true. Omar, thank you for that very good, nice presentation about the X-ray and the CT finding. Very important to us is, irrespective of the CT finding or the X-ray finding, what's important to us clinicians is how the patient is saturation, the oxygen saturation of the patient, because that determines if the patient is going to need intubation or the patient is going to or not. Also very important, I must note, is that COVID affects all the organs in the body, not one is spared. COVID affects the brain. So most of our patients present in coma. COVID affects the heart. The virus could enter into the heart and cause what we call viral myocarditis. So most of these patients would come with heart attacks, heart failure, or even sudden cardiac death. COVID affects the kidneys and causes kidney failure. We have, of the patients who have been severe, almost all of them in the ICU have needed dialysis, hemodialysis, urgent hemodialysis, while in the intensive care units. COVID affects the gastrointestinal tract and also the liver. So most times it damages the liver and it causes very high liver enzymes. So typically all organs of the body are affected. So, and this determines the overall prognosis of the patients. So when this patient come and we got the chest X-ray, so the chest has to give us a clue, pending when the nasopharyngeal swab results comes out. So for a patient who confirmed COVID, it's important that what's important is that we monitor their oxygen saturation. This determines who gets intubated. I think the bottom line of the management of COVID patients with that affects the lungs, that we're talking about those patients who have severe disease, having ARDS, which is acute respiratory distress syndrome. Those are the patients that we're very keen on because it determines who gets intubated or not. But what we try to do sometimes is to buy time. We try to buy time for intubation because there are various studies that are saying that intubating a patient, putting a tube down the patient's throat and connecting them to the ventilator worsens the overall prognosis of this patient. In my own experience, a typical patient spends 3 to 4 days on the ventilator for any other reason. But COVID patients are spending up to 20 to 30 days on the ventilator. I have patients who have 20, 34, 24 days on the ventilator. They find it difficult to get them extubated. Most of the patients sadly pass while they are being ventilated. So because if you read the news, there's this big thing about, oh, ICU care, how many ventilators, and all sorts. So we're putting it out there right now that in as much as ventilator is important when the patient is very short of breath and patient is hypoxic, if you can buy time and prevent intubation, it might improve the overall prognosis of this patient. So for patients who are short of breath, we start by giving them oxygen. Oxygen could be given through nasal cannulas. Oxygen could be given through face masks, non-rebreather. Oxygen could be given through what we call the BiPAP. The BiPAP, that is giving the positive pressure airway ventilation systems.
Ventilation,
yeah. So that's another way we can deliver oxygen to this patient. However, we try to avoid the BiPAPs because it's an aerosolizing procedure. It spreads the aerosols out, and healthcare workers are typically at risk for those patients. So these are the ways we supportively manage them. And when it comes to medications, right now there's no proven medication that works for COVID. I'm sure everybody knows that. So there's no magic medication that you give to this patient and they just improve. There's these trials, a lot of trials are going on. I know the hydroxychloroquine, it's been given to everybody, and we saw the news where the president of the country.
We're going to talk on those trials because we have a clinical research specialist in our midst. I don't intend to cut it short, but because we're almost out of time and questions are pouring in, over 30 questions. I want us to just touch a little bit about every little questions and clear their doubts so that they could come back next week and ask more questions. Okay, so Egbe, I know you're ready for transmission. So when we get to those questions that cover transmission, you're just going to talk about it a little bit from there. Let's just go on. You've talked about treatment modalities, what you do symptomatically, what you do definitively. There's no definitive management. Are we looking at future management? So we have a clinical research specialist that's going to talk about what people are doing, what the science world is looking at, because there's this thing out there that everybody thinks is vaccine. Meanwhile, people are doing a whole lot. Dr. Jai, are you still there? Yeah, okay. So Dr. Francis, can you just briefly, in less than 5 minutes, just specifically mention these newer approaches of managing this disease one after the other, newer approaches that we're proposing, not actually managing, they're proposing, like in 5 minutes, we're rounding up in the next 5 minutes, we're going to take questions and to go around everybody. There's questions for everybody, including Mrs. Barr, who has given us privilege to be with her today.
Sure. Thank you all so very much. Thank everyone, and thank you for having me. Ms. Barr, hopefully, I'm thankful you're recovering very well, and thank you for joining us and sharing your experience with us. From the clinical trial perspective, I know people have lots of questions about how do you manage, how do you prevent, and how do you treat this? We all have heard from our colleagues, there's no known treatment for COVID-19. And the role of clinical trial is to try to figure out how to prevent post-exposure prophylaxis or treatment, how to prevent this virus or the development of vaccines. Now, let me just say that I know, Ms. Ba, you mentioned some things that you took and it may have helped you. And yes, I agree, it could have helped you. We don't really know. Now, speaking from the data point of view, I'm a data-driven person. I would say that there are no approved therapies for the treatment of this COVID-19 or even the prevention. There are lots of trials that are that are ongoing currently, and the whole idea is to figure out what we can put out in the market. Clinical trials are very expensive. The pharma companies are spending a lot of money, and at the same time, they're trying to bring out a product that will be safe and effective. Now, the product has to be safe and effective. It means that it has to be tested over a period of time. So it's not just going to come out there in the market without having data that supports or backs up its safety and efficacy. Having said that, there are quite a number of products that are being tested currently. I'm going to use some medical names here. Most of us are familiar with those names. There are what I call the vaccine development itself. And then there are other things that are being tested. It's called convalescent plasma, interferon-based therapies, small molecule drugs, cell-based therapies, and also monoclonal antibodies. Someone mentioned anti-malaria. Yes, anti-malaria is also being tested. All these tests are currently ongoing. the whole idea is to, at the end of the day, hopefully within the next few months or even a year, have data that we can submit to regulatory authorities or bodies that would eventually approve this product to go to the markets. So that's where we are. That's where we are. I have a slide. I don't know if time is going to allow me to share some of the slides.
Dr.
I can
Francis,
share that on
are you there?
Yes.
Dr. Francis, are you there?
Yes, I'm here.
Dr. Joseph, can you hear me?
Yeah, I can hear you clearly.
Can you hear me?
Dr. Joseph, can you hear me?
I can hear you, Francis. I can hear you, Edward.
Okay. I don't know. Am I breaking up?
Yes, yeah.
So we seem to be having some technical difficulties.
I see. Can you all hear me now?
Yes, I think it's resolved now. I can hear you clearly.
Okay. So what I was saying before that was, I don't know if time will allow me to share. Maybe I can share the screen some other time. I can share some of the screen now. Some of the things that, some of the drugs that are being tested. And
because of time, we're almost out of time. So we could just go through the question. We'll continue this episode every Sunday. Next week, Sunday, we're going to go into specifics. What are the trials? What figures do they produce? What numbers are they giving us? Are they hopeful trials, or are they just out there? So we're going to go specific. This trial is being done in NIH. This trial has been done in China. This was done. That's what we're going to do next week, and some other things. I know this COVID-19 has had a whole lot of toll on the economy of man. Dr. Zainab, you are a medical economist. Can you tell us what we're feeling? What is the world feeling? I know everybody's feeling it differently, but you could just wrap it up in 3 minutes. Then we go back to Dr. OJ and take some questions for everybody. Dr. Siri, you have a question. Egbe, you have a question. So many people have questions for everyone. Go ahead.
Good evening, everyone. My name is Dr. Zainab. I'm a general practitioner as well as an entrepreneur. Can you hear me?
Yeah, sure. Go ahead.
Okay. I guess my time will not allow me. I actually have a lot to say concerning the economic effects of COVID-19, especially in Nigeria, where we reside presently. There's been a lot of difficulties here in Nigeria economically. It's very important to understand that coronavirus is not a death sentence. It's not a death sentence. And it has come with a lot of challenges as well as a lot of opportunities. While many companies are actually hurting right now, we have a lot of companies who are actually sacking their employees. Others are actually reducing the salaries by maybe by 50%. Some are giving out 25%. Some are not paying at all. Some are hanging. They don't know if they actually have their jobs or they do not have their jobs. So there's a lot of uncertainties concerning the economy, especially in Nigeria. So, but in as much as this has a lot of doom, or this is presenting a lot of doom, there's also a lot of opportunities, especially for small-time entrepreneurs. And I'm going to talk about that. I'm going to talk on that aspect. The Nigerian business landscape is radically changing. It has changed radically in the past few weeks. While some businesses are actually going down the drain, some are actually coming up. Examples of these businesses include the delivery businesses. People are making delivery, buying things online, via online, buying food items. Grocery stores are actually going to the bank and getting a lot of money because people must eat. That's why no matter the surge of the disease, no matter how biting the disease is, a lot of people will have to eat. And because of that, we have a lot of these delivery companies as well as grocery stores that are making a lot of money now. So what I'm trying to say is that in as much as it looks like because of the COVID-19, there's a lot of issues concerning the finances. There's a lot of issues like people are thinking, how will I survive? How am I going to eat? But what I'm trying to say is that despite all this, there are ways and you can actually key into this and actually get something or get a source of
make the
income.
best out of what you have.
Make it the best of what you have. Examples of how to go about these things are like the face masks, for example. We have in Akwa Ibom, the governor has set up a very big company where a lot of people are now manufacturing face masks, Ankara face masks. People can actually key into that. People have started doing it in Abuja here. We can actually try to make face masks in different types of Ankara and sell it out. And then if you can key into that, you can actually make a lot of money while doing that. For those that have supermarkets and grocery stores, they're actually making a lot of money because people will have to eat no matter what it takes. So people are going out and buying groceries. So if you have the small capital to raise, maybe start selling small things around you, even your house. You have a lot of customers and people can come in and then buy one or two things from you as well.
Oh, sorry, Dr. Omoye, sorry, I don't mean to cut you short, but we're really out of time. We're just going to take a lot of questions, and there are questions for everybody. Dr. Joseph will begin. Dr. Omoye, we're going to have you again next week, Sunday. We'll continue with this economic trend, what we're going to do and what no, we're not going to do, okay? Then we'll just wrap up in 3 minutes. Dr. Joseph, COVID-19 has been detected in amniotic fluid. Someone asked that, a doctor asked that from one of the countries. I can't go to Facebook now. So is there a data suggesting mother to child transmission? Can you just quickly talk on that?
Like I said earlier, the disease is still novel. And for now, few studies are still available from China, from UK, from US, and none of these studies have reported vertical transmission from mother to the baby. In fact, breast milk transmission has also not been reported, unlike we have in regular viral hemorrhagic fever here, Lassa fever, which is currently ravaging many communities, and vertical transmissions often reported. But for COVID-19, no vertical transmission has been reported as of now. But definitely, there is need to do more studies because very few cases have been reported in pregnancy. And even in Nigeria, I'm not sure we've reported, we've really managed a woman, we have a woman currently with COVID-19. Was only reported retrospectively in a woman who died following a procedure. Was diagnosed to have COVID-19.
Thank you. So bottom line, we're still looking at it. We're not sure yet if there's going to be, that's what you're trying to say.
Vertical transmission. For now, it has not been reported.
Has not been proven.
Yes,
all right,
yes.
But in UK, I think Dr. Egbe is saying that in UK, they've seen newborns with the disease, but it's not clear if they got it through vertical transmission.
Exactly, that's what it is, or from maternal transmission after delivery.
Quickly, Dr. Cyril, a lot of people have ocular problems, eyesight problems. Have there been documented COVID-19 eyesight problems?
Thank you very much for having me. Yep, there's been documented ocular complications resulting from COVID-19 infection. And you know, since COVID-19 is still novel and we're still going to learn a lot about it, I believe we're going to be seeing more ocular involvement. Studies that came out from China which documented a follicular conjunctivitis in relation to COVID-19. The follicular conjunctivitis normally occurs in allergic reactions, where you have a type of conjunctivitis that is classical on examination. So a red eye can be a symptom of COVID-19. And so ophthalmologists all over the world are currently very careful when examining patients who present with red eye, because red eyes have been documented to be a sign of COVID-19. It's also instructional to note presently that reverse transcript PCR done on eye swabs, specimens taken from eyes, have yielded COVID-19 associated with the SARS-CoV-2 virus. A recent article that came out documented persistence of SARS-CoV-2 in conjunctival samples up to 37 days post viral clearance. And so it's important to note that, especially for the eye care practitioners who may be watching us, that it's important to view patients with red eyes, especially if you're in a country or in an area with active, ongoing COVID-19 transmission, to view patients with red eyes as possibly having COVID-19. So these patients should be examined using a face shield and a face mask. While the patient is also wearing a face mask, your street lamp should have a face sheet, a breath shield installed on your street lamps so as to prevent the practitioner from contracting COVID-19 from patients who may have this and may not know about that. Thank you.
So thank you so much. I know there's a lot of questions coming from Facebook feed, from YouTube. We can't touch all of them. We'll just quickly go to a question that we enable Dr. Egbe talk about. Just 1, 2, 3, 2 minutes on prevention. I'll combine the questions together. So let's say Miss Barr is a survivor, right? Are there studies suggesting that she can get it again? How does she prevent herself from not getting it? That's number one. There's another question that's coming from the feeds. So Dr. Cyril, if someone is crying, shedding tears and touching his eyes, can the COVID-19, has it been documented that it has been seen in tears, that you could transmit it to? Because people cry and someone consoles them, maybe in the burials. So Dr. Egbe, just quickly 2 minutes on what can I do not to prevent it?
So what the message is out there, and I think that it's just to buttress the point that, first of all, people may be asymptomatic. So they may be well, they may not be coughing, they may not have a fever, and there is potential that they could shed the virus and people could get it. So by staying at home where possible and as much as possible, and by avoiding contact with other people, you minimize the risk. Having said that, symptomatic patients, so patients with symptoms, are the ones that are more likely shedding this disease. So if these patients wear face masks, so the patient themselves wearing face masks prevent them from shedding the virus when they cough or when they sneeze or when they talk. If you're not in close proximity with symptomatic patients, then you reduce your chances of catching the virus. This virus also stays on surfaces. So if somebody with COVID-19 sneezes, for instance, and it's on a desk or it's on a handle of a door or it's anywhere they've touched, let's say they sneeze into their hand and they've touched somewhere, then that surface can remain, the droplets can remain on that surface for up to 3 days. So if somebody else touches that surface, then they can catch the disease. And this is why hand washing is extremely important. Frequent hand washing with soap and water for at least 20 seconds prevents you from carrying that. If you've touched a surface and you've picked up the droplets of the virus, if you then touch your face, your nose, your eyes, your mouth, then you can get ill with the virus. So if you wash your hands frequently, especially if you've been outdoors, it helps you to reduce your chances of getting it. And again, if you stay at home, you are less likely to be touching surfaces that everybody else has touched anyway. So even when you go grocery shopping, it's best to minimize that, just to maybe once a week or once every 2 weeks, because for everything that you touch, if someone else with COVID-19 has been there, it may still be on that surface. So the sickest patients may transmit the virus more. So for those in healthcare facilities, the doctors and nurses, as one of my colleagues mentioned earlier, will be using full protective equipment to prevent them from getting the virus. So simple things like hand washing, social distancing, at least 6 feet, because the virus is quite heavy, so it doesn't travel too far. So if you stay at least 6 feet from people, then that again means that if they speak or if they sneeze, then you are unlikely to be in contact with the virus. So those are simple things that we can do to prevent.
Thank you so much. Thank you so much. I'm not trying to cut you off. We're just trying to minimize time as much as possible. Quick last comment. Next week, Sunday, we're still going to come back. Dr. Egbe has talked so much about prevention, but we're going to go into detail. How do you wash your hand? What do you prefer, soap, or do we prefer alcohol, or what type? Dr. Omar is going to talk about the nuances that we hear every day. We're going to go into treatment proper, the anecdotal treatments that are out there. That is the herbs, the lemon leaves. Dr. Francis is going to cover newer researches, The ear, nose, and throat doctor with us hasn't said so much because this disease is actually inhaled. We're going to go into medical receptors. How is this? What receptors are responsible? Are the receptors in the mouth? If I kiss, can I get it? Or is it just the ACE inhibitor, ACE receptor, ACE2 receptors on the respiratory tract? Can I get it through my skin? Can I get it through intercourse? Can I get it through other means? So we're going to come back, economic effect. Next week, Sunday, we're going to come back. But before we go, Dr. OJ, can you just summarize in summary what the takeaway key points that each of these specialists has actually raised today?
All right, thank you for everyone for your time. I think it's important for us to put it out there that COVID-19 is real and anyone can get COVID-19. All right, but what also I think it's very important from all we've talked about today is what message do we send out there to keep people encouraged? I know during this lockdown, it's a lot to bear, but it's very important because this is one of the strategies that will limit the spread of the virus. And also for our colleagues, healthcare workers who want to know more about what's going on. I think we have, in this few minutes, been able to put something out there. We hope to continue. You could send in your questions and everything would put it up together and give a more robust presentation next week. I hope that by then, this pandemic would be showing some very good light of it ending very soon. I think that's all I would say for now.
Thank you so much. Thank you so much. The survivor of COVID-19 that we have in our midst, Ms. Barr, I hope I'm pronouncing your name correctly.
Yeah.
Thank you so much for being with us. Thank you to all the specialists and every other person in our panel. Thank you for the questions that are coming in. So many questions, over 50 questions. We can't take all of them out. We can take same time, same station, next week, Sunday. We'll meet you all. Thank you so much. Keep your questions coming because these specialists are going to look at the questions and they're going to answer it if we have time. Next week, we're going to continue from there. Thank you. It's a new virus. Everybody's learning. I'm learning. The specialists are also learning. Everybody's learning. We'll get there Sunday. Thank you so much and goodbye for today.
Okay.